health directly or those interested in public health, both here in the London region, but increasingly across the country as we widen participation and the opportunity to learn with public health colleagues across the country. Today's Public Health Forum is an exciting one. We are in the midst of a transformation of the health and care system in England, perhaps one of the most radical transformations of the NHS that many of us, especially those starting our careers, will have experienced to date. And we wanted to take the time today to reflect on the nature of the changes which are occurring in the NHS and to ask critically, what are the implications for those of us working in public health? What are the implications for those not working in public health, but have ambitions for improving population health, tackling health inequalities, and improving quality and outcomes for Londoners and those across the country? So throughout the course of the forum today, you'll hear from myself doing a little bit of scene setting at the beginning of the morning, followed by reflections from leaders from the London health and care system. And I'll be introducing the speakers as we progress throughout the course of the day. The objectives of today's session are, first of all, to reflect on what is new in public health leadership and some of the core skills that we may require in order to navigate system transformation. Second, to provide a better understanding of the nature of the organisational restructuring which is taking place within the NHS and the implications for those of us working in public health. Third, to hear from system leaders about how they're interpreting the 10-year health plan and related policy documents and where best to position themselves, ourselves and our systems to take full advantage of the 10-year health plan. And finally, we'll be hearing from you, your questions, your comments on how we maximize the impact of public health within the settings. Now, before we jump in, a few housekeeping announcements to get us started. First of all, let me remind you to stay on mute unless you are speaking today. In order to preserve the bandwidth for the session, I'm going to ask you if you could turn your cameras off during presentations. And third, I'm going to ask you to engage and ask questions. The chat is available and open, and we really welcome your reflections, your comments, respectful comments in the chat. Throughout the course of the forum, we will be answering questions and engaging with you as well. So please do ask your questions. We have senior leaders from the NHS, senior leaders from OHID, and UK HSA on the call today. And we're really here to ensure that everyone gets value from this session. Finally, a reminder that this webinar will be recorded and all the slides used will be shared after the event. And if you require live captions, please select the 3 dots at the top of your screen and click Turn on Live Captions in order to receive the captions for the meeting. So, without any further ado, it gives me great pleasure to get the meeting started today. And I've been asked by the organisers to set a little bit of a scene because, as you know, I've been thinking through and discussing opportunities for public health leadership as we go through significant change within our health and care system. And many of you would have had a chance to review and read an editorial which I had recently published in the Journal of Public Health, which really reflected on some of the new leadership skills that will be required of us as we navigate complex and uncertain times. Because this Public Health Forum is focusing on transformation and the opportunities for leadership, I thought I'd just share some of the key tenets from the editorial to get us started today. And after that, we'll begin with the first fireside chat with my boss and colleague, Caroline Clark. So, leading in complex and uncertain times, we are going through significant transformation now in the health and care system. And for many of us who've worked within the health and care system, this is not new. It's perhaps not as radical as previous ones that we've experienced. Nevertheless, it is change, and it's changed during very challenging times. And in order to navigate that, I think there's some new skills, new competencies that we are going to need as public health colleagues. So I would argue that we're living in not only complex and uncertain times, but public health, both as a profession, as a skill set, where we're placed within the system, will experience unprecedented challenges. And this is likely to occur domestically here in the United Kingdom, but also if you are looking at what's happening globally, you can see similar threads of threat and challenge to public health occurring in other Western industrialized countries as well. Now, the nature of these threats are many. They reflect differences and changes in financing of public health systems, trust and advocacy for public health, and what is being prioritized domestically and globally as nations deal with multiple concurrent threats. They also reflect growing public health challenges that we're dealing with as well, stagnating or declining life expectancy and healthy life expectancy, major challenges with environmental and infectious conditions and disease threats, and of course, widening inequalities here in the United Kingdom. And this is further complicated by what's happening in the global space, whether the economic stagnation that many countries are now faced with, the epidemic of disinformation and political instability, reprioritization of government spending away from health towards economic growth, or in many countries now to prepare for defense and increased defense spending. All of these will have interconnected impacts on what we do in public health. So the question then for us for today, and I think for all of us working in health, but specifically in public health, is how might we think differently about the role and leadership of public health in this changing, dynamic and complex environment? Well, in the editorial, I highlighted 7 things that we may want to focus on during this time. And these 7 are not to say they're not other priorities which are critical, but are here to stimulate conversation and to stimulate our thinking in how we might do things differently. I think one of the big challenges that we will have to face is widening inequalities and how those widening inequalities have knock-on impacts, not only on health, but on social cohesion, on economic employment, on people's focus on how the society is working for them and their engagement in society. And post the pandemic, we have seen stagnation of life expectancy and healthy life expectancy in many Western industrialized countries. And unfortunately, the United Kingdom has been particularly hard hit. In dealing with and confronting these inequalities, I argue that we not only need to understand the drivers of these health inequalities, both in terms of the rising tide of chronic diseases and the risk factors which drive those chronic diseases, but also to think critically about healthcare systems and whether they're geared up towards tackling inequalities by working with communities, engaging and tackling structural discrimination and the forms of stigma and discrimination, and to think about ways in which we identify the most effective interventions and to apply them at scale to tackle these inequalities. The second thing I reflected on is the importance of the global crisis of trust and disinformation. And I think the World Economic Forum, in their ranking of global risks, ranked by severity, placed misinformation and disinformation as the #1 threat facing global societies over the next couple of years. And this is critically important. We've seen its impact during the COVID-19 pandemic. And as we've emerged from COVID-19, we've seen the impact of misinformation, disinformation, and mistrust on a range of public health interventions. We cannot assume that people are going to be engaging with vaccination, with screening, with health promotion, with health education in ways that they did 10, 20, or 30 years ago. And in an environment where fact-checking is being removed, and in an environment where everyone becomes an expert, how do we cut through? How do we focus on most important things which we need to communicate and engage the public with? And how do we manage trust and truth in an environment where there's trust and disinformation? What role do we have as public health practitioners? A third area that I argue in the paper for is changing our leadership styles and really moving away from hierarchical leadership models, which I think are no longer sufficient, into thinking about how we become more adaptive, more agile, and perhaps more disruptive in thinking about our voice, our advocacy as public health practitioners, how we navigate complexity and how we challenge entrenched systems, and how about making bold decisions rooted in equity and justice and doing so unapologetically. In this slide, we talk about some of the new skills in adaptive leadership, which I think are critically important, which I know myself and Dame Caroline, when you hear from her, employ every day, whether it's really building upon and strengthening our emotional intelligent leadership, working towards organizational justice in terms of how we share information, focus on fairness, focus on quality and outcomes, really think about values and character, integrity, credibility, and understanding where and how differences occur in our values, but also our commitment to lifelong learning as well and developing others. Key skills which are effective for us to lead and to manage in a widely changing environment. I also talk about the importance of building cross-sectional partnerships in the editorial and really thinking differently about how we collaborate, how we value partners, how we sustain partnerships, the nature of effective partnerships, and how we use metrics that not only focus on clinical outcomes, but we begin to measure the quality, effectiveness, and impact of our strategic partnerships. Now, there are many examples of effective partnerships in London, and in the paper, I reflected on some of the work being done in North East and North Cumbria, but there could easily select lots of examples from London, from Thrive or work on fast track cities, the transformation work that's being done in the NHS at the moment, which really is building upon new models for cross-sectoral leadership. The fifth area is around how we engage communities authentically. And given the fact that we are dealing in an environment of low trust, of misinformation, disinformation, where communities feel poorly connected to health and care systems, now more than ever, as we learned during the pandemic, bringing communities closer to us to co-produce, to challenge, to improve the systems that we're developing, which improves engagement, uptake, and outcomes, must be the way forward. And the key question that we have to ask ourselves is, are we using the range of tools which are available to us to engage communities authentically? And how, when systems are under strain, financially and otherwise, do we still keep that focus on community engagement, mobilization, as a critical part of getting our job done and getting it done well? The final 2 areas that I focused on in the paper are really around things that we need to do to address anti-racism, structural discrimination, and to use more frameworks for driving equity, ensuring that those frameworks are both in the structures of how we organize ourselves and how we design our systems, but also in the values that we espouse, the ways in which we treat our staff and our workforce, the programs that we deliver, the role that our organizations have as anchor institutions to be that voice and advocate for structural discrimination and anti-racism. And again, incorporating work with our communities to do better when it comes to addressing discrimination and creating better frameworks for equity. This is, I think, increasingly important as we deal with more diverse populations with different needs, but also as our workforce increasingly diversifies, to ensure that we're creating safe and effective environments for workforce to do their best work. Finally, the 7th area that I focused on in the paper was really around professional development and sustaining leadership capacity and capability for our leaders. It is important not just for those of us working in the system now, but as we think about future generations who will be called to lead in the system. Do we have national programs? Is there dedicated resource for development? Are we focused on professional development and personal development in these challenging times? Can we support our staff to support their resilience? And are we building learning systems? All of these are critically important for us as we adapt and as we work in these very complex systems. So, colleagues, I wanted to start a scene today by just reflecting a little bit on the nature of the changes that we're experiencing. And I end the paper by calling for public health practitioners to embrace new leadership paradigms which are based on adaptive leadership, which continue to be equity-driven, which are collaborative, but most importantly, rooted in trust and in justice, especially in these challenging times. It's important that we don't do this to communities, but with communities, working together to confront disinformation, building partnerships, and embedding work on discrimination, and really leveraging the assets that we have to deal with the complexity of our times. So with that, colleagues, just wanted to spend a few minutes to reflect on the nature of the leadership challenge. And with that, I'm going to now shift to the second agenda item for the forum today, which is a conversation with my boss and my colleague, Dame Caroline Clarke. Now, many of you will have seen Caroline's bio in the briefing papers that were sent out today, so I'm not going to go into any great detail, but Dame Caroline Clarke is the Regional Director for the NHS in London, and she's leading the NHS's work in the capital with an ambitious agenda to improve the health and care of the population and communities that we serve, with a focus on continuous improvement and innovation and the use of data and technology. Caroline, great to see you, and thank you so much for joining us this morning.
Thank you for having me, Kevin. It's nice to see you. Hello, everybody. Morning.
Wonderful to see you. So, Caroline, you heard my presentation. I'm going to start by just hearing what you thought about some of the key principles there. Did they resonate with you? Are they different to what you're dealing
Totally.
with and grappling with as well?
No, it's all the same. It's all the same. I live in London, so I've just gone through that whole weekend of, a march based on fear, lack of trust, lack of information. I've seen all that. Everything you just said totally resonates. And I suppose it was making me think about well, actually, your 7 categories, I can't. They're exactly what we all need to do, but very specifically, public health professionals kind of leading the way in some of this. So, I can't. I've always thought that we need to turn to public health professionals to understand emerging risks, which I think is what you're talking about. You are the people that are much better at system thinking and bringing together perspectives and information from different parts of the system. So it was from public health professionals in the 1990s, and I worked in Camden, Islington on do you remember the HIMPs, the health improvement plans? That's where I learned about system thinking, first of all, right? So it's people on this call that know much more about that. It's public health professionals that taught me about health equity and that you need to concentrate on reducing disparities in order to drive everybody's standard of living up. And it's public health professionals that taught me about trust and engagement. So those kind of 4 things actually fall into your categories. So yeah, totally. And I hadn't practiced. I hadn't seen what you were going to say before. So spot on.
Wonderful. Well, Caroline, as I said at the beginning, the NHS is going through transformation again. And for those of us in the middle of it, including ourselves and many colleagues on the call today, this may feel pretty radical and pretty far-reaching. And I just wondered if you could briefly summarize the nature of the changes. How do you see it all coming together, from neighborhoods to providers to the new ICBs, etc.? How would you tell the story of the transformation that we're going through now?
Well, I suppose you have to take a step back and think about. I mean, the 3 shifts that this government talks about. I mean, most of us on this call, right? I'm 56, so I have been talking about this probably not as eloquently for a very, very long time since I joined the NHS in 1991. So this desire to push care out of expensive hospitals down towards where I, as a human being, live, work, receive other services. This desire to be more preventative in our aspiration, and more lately, I guess, this desire to use these fantastic technologies that we have available to us. So, I guess that's what we're trying to do, and we're trying to make it easier for me as a human being to engage with health and well-being services, I guess, and to try and ultimately shift so that I can take more control of what's happening to me. And that's happening in other parts of our lives as well. So I'd start with that. And I'd start with the pace of change as well. I think there's something in that I might amplify around that the level of change now in the rest of my life is so fast. And I can see the level of change in what's happening in other countries and other health services, and we're not fast enough in this country. So I think there's a bit of that. I think there's an awful lot that we can do in that left shift space without reorganising ourselves. But nevertheless, we're doing that. There's some politics in this, and you can see the politics are febrile at the moment. So again, I've read every variety of newspaper over the weekend, and it's just bonkers. So, and I guess there's something about the closer you are to it, the more you see it. So I sort of have to go and check in with my friends that don't work in the NHS and don't have jobs close to government to check they're seeing what I'm seeing, and I think we are. So I think let's remember the things we're trying to do before we get kind of over influenced by some of the very short term, quite difficult things we're going to have to do in terms of sort of restructuring ourselves and stuff.
Yeah. In the new structures, the regions have been the recent model for the model region was published, I think, last week.
Yeah.
And I know that you and a number of colleagues have been working hard on that. Can you summarize some of those changes for us? What excites you about the changes?
Yeah.
And how might you see public health fitting into the new region? Yeah.
Yeah. So I think most people on this call are from London, aren't they? So in some senses, quite a lot of what's in that model region is sort of what we've been trying to do in London. So the thing that probably is more amplified in the model region document, and it's on the NHS website if people want to see it, is our strategic and transformational role in the future. So it's kind of three roles really. One is strategic transformational, looking at the whole health system. Secondly, there's some stuff in there about sort of regulation and kind of when things go wrong. And thirdly, a strong emphasis on kind of performance management and health improvement. I want to talk more in this call, Kevin, I think around the strategic and transformation role, because I think public health anchors that. So for me, having a really strong, I mean, I would say this whether it was you or not, but it's really helpful having you around my table, part of the team, part of the leadership, and then really having a strong sense of, well, those four things I started with actually. So it's you and your teams that will tell us about emerging risks. It's you and your teams that will help us do the system thinking. It's you and your teams that will help us concentrate on reducing disparity and promoting health equity. And it's you and your teams that will help us on some of the sort of issues around community trust and engagement. So I think it all starts with public health. I mean, I would say that anyway, whether I was talking to public health professionals or not. And so if part of my job is to recast the London health strategy and the London priorities using public health data, then we're going to be busy and we're going to be spending quite a lot of time together, I think. So I think it's those three things. And then I suppose just for people that work in NHS England or people that work in ICBs, it's quite hard when people publish these kind of model documents that are blueprints because they're essentially quite high level. And of course, a lot of the feedback I hear right at the moment is, well, I don't see myself in there. I can't work out where my team is. I just think, okay, it's easy for me to say this, but don't worry too much at the moment because this is a very high level document and we haven't done the detailed design yet. I think people in your space, Kevin, might be wondering about the relationship with local government in all this, because of course, lots of people in this call, I imagine, will be working for local authorities. It's more important than ever for me. So this thing about systems thinking, this thing about locking us all in together to try and address some of the common issues that we all face. Now is the time. So in London, of course, we have a health and care leaders group, which is colleagues in the GLA, colleagues in local government and colleagues in the health service, all meeting very regularly to discuss many of these kind of issues of public health. We're going to do a lot more of that in the future, I think. And so one of the things we have to think about is how do we amplify that work and how do we make sure that we don't just meet in a room, that we cascade that and that we bring other people and other parts of the system together. I was really thinking, I used to be the chief executive of the Royal Free, and we covered one of our hospitals was in Barnet. And just before the pandemic, we had a lot of conversations about the Barnet pound. Wouldn't it be better if we treated, kind of public sector resources even without doing it in a statutory way, and really start to align and make sure that we had common priorities and that we could sort of pursue, a small number of strategies together. And I'd love to get back to that way of thinking across London. It's very difficult because, of course, money comes in different ways and treasury levers and incentives are different. But I think there is, without wishing to be naive about it, I think there is something about us aligning and using our resources more consistently and collectively.
Yeah, I think you're absolutely right there about how we align ourselves. And I think viewing the transformation that's happening as an opportunity for us to go further and faster with our collaboration rather than to retreat from collaboration, I think will be one of the leadership challenges that we have. I often say that when systems are under strain, systems tend to focus inwards and organizations focus inwards rather than actually saying, now's the time for us to reach out, begin to think about how we work together. And in the spirit of that, I know that there have been changes at the ICB level, the merger of North Central and Northwest London, really preparing for the new world that we're going to be living in. And London really was off the mark for us with thinking about its neighbourhood structure as well. And I just wondered if there's anything with those two strategies that you wanted to highlight to this group, because I know many public health colleagues are interfacing either at the neighbourhood level or the ICB level.
I think, can I say two things really? One is about the sort of role of ICBs, and then I want to say something about how we use data, because I think people on this call are kind of a bit fundamental in this matter. So on the so ICBs have got a really important part to play now in how we commission integrated neighbourhood teams and how we start to provide. As a Londoner, I kind of want to know what I'm going to get. I want to know roughly. It might not be the same in sort of Holloway where I am versus Harrow, but I want to know roughly, who's what sort of services should I expect? When might they be delivered? And how are you going to use data to serve your ends? So I think it must have been April this year. I've kind of slightly lost track of time, Kevin, but I think in April we put out some what we thought a good operating model for Londoners might look like, and we did a lot of work with Londoners. I think you've got Andrew next, haven't you? So
yes,
hopefully he'll talk a bit about this. But it's such an important part of what ICBs are going to do. It's commissioning role. So that's first thing to say. And of course, ICBs are going to be commissioners. Now, what does new commissioning look like, and how does public health fit in? And I think there's something about how we use data in all this. And I just wanted to say a couple of things about how I think the emerging technologies and data is changing from probably more traditional public health surveillance to actually future-looking strategic intelligence. And my hunch is that we now have kind of more multi-source information from different parts of our lives, and I see public health professionals bringing that together. So whether it's data you get from waste management, sewers, or whether it's data from climate, or whether it's data from education or housing or social care, we got to get better at bringing all that together and being more predictive. We got to get better at using that data in real time. Saw some of that in COVID. Also saw how we struggled in COVID, Kevin, with like multiple spreadsheets. Now,
that's right.
That should not be the case now. So we should have the technology to bring that stuff together. And then, of course, thinking about kind of how we address mistrust and community engagement. Actually, we've got much more granular data that can tell us how to reduce disparities. Now, we have to do that ethically. And again, it's one of the things that I hear public health professionals saying more is a kind of, this has got to be, managed really, really carefully. But I think in how we service integrated neighbourhood working, which will be at that level, we will be more predictive. We'll be able to be more personalised, and this huge ethical issue, how we govern and all that stuff is really important. So I suppose I just wanted to say that because it gets lost sometimes in the integrated neighbourhood thing, and everyone gets worried about ways of working, but it's going to be so different, and it's going to be different in, like, I'm 56, it's going to be different in my working life. So it's soon. So we need to get on it. And, I spent some of my weekend, apart from worrying about politics, training myself on AI, how to use AIs, because I just think, and I look at the kids and they're all doing this, so
that's right. Yeah.
We got to do it. It's on us. It's on the leadership to get tooled up, I think. So that's important.
And that's why point 7 in my presentation was around professional development and building the capacity and capabilities that we need. Because as professionals, we cannot sit still, right? Because the external environment is changing so rapidly and so dynamically. And the tools that we have available to us to do our core public health work are fundamentally different to what they were when I started in the 1990s as well. So I'm going to move us on, because I know one of the areas that you're really excited about, and I am as well, is transformation. And since starting as the London director, you've really helped, I think, the systems to focus on a few things that we do well to transform health. And I wondered if you wanted to give us a taste of some of those transformation initiatives, and what are you learning about driving transformation in the midst of complexity?
Okay. Well, so thing number one, we worked with ICB colleagues over the last couple of years to think about what are the 5 or 6 things that we can do at our level and we should focus on. And there were a cluster of deliberately digital first, shift left type things. So I got very influenced a couple of years ago by seeing what parts of Sweden. I was in Gothenburg and they were showing me their sort of digital triage system. And it did occur to me, particularly for more transactional types of healthcare, it was really effective. So I got quite, so it's this idea of having a digital front door, which of course is now kind of, in the 10-year plan, but help me into the system. And it won't be right for everybody, but it will free up time for general practice and other healthcare professionals to deal with more complex patients. So help me into the system using a single front door, or if I can't use my smartphone, dialing 111, but give me the same level of service, and then understand my risk. So give me access to have access to my healthcare records. Lots of ethical considerations around that, but segment me appropriately, send me to the right place in the health system, be it a community pharmacist if that's all I need, or a GP, or a hospital if that's what it takes, but do it much more intelligently than we currently do. And then let's use some of the emerging technologies to really test whether we can have sort of digitally diagnostic pathways. So for example, many people will hear me talk about skin. If I've got a mole that I'm not sure about, we now have the technology to take a picture of it and get it triaged using an AI assisted program. And that is, MHRA and NICE accredited, and we should just do it. It's been really difficult to get that commissioned once across London. It's been impossible. And of course, as a region, we haven't held a budget. Now, in the future, we might hold a budget, and then that becomes a bit easier to kind of engineer. So digital front door, AI assisted digital diagnostics. Similarly, if I have an urgent eye care problem, why can't I just look into a camera? Now, I'm not a clinician, but we have an agreed pathway that we should just have for Londoners. So think like a consumer. That's the first thing. Think like a patient or a consumer of healthcare, and design your system around me. We've asked patients what they think about having digital, using technologies and data, and they're up for it. We did a whole deliberative series of events last year. People are much more up for it than we as healthcare professionals think. So that's the kind of digital stuff. And it's all in the 10-year plan, and we just got to figure out how we get it commissioned once. Then we know that mental health services in London are really variable, and if you're a user of them, you get an inconsistent service. So trying to put some work in place to just get particularly a more consistent community offer if you're in crisis, that's really important. So I'm going large on that this year, and I'm really grateful to my colleagues that work in mental health. And then a final thing I wanted to talk about is integrated neighbourhood teams. So that is a really big plank. Everything is underpinned by what happens to me when I kind of walk out of my front door and I get seen in my community. So that I'm glad you led off with that, because actually that is probably the most important thing. I haven't talked about child health, but we need to have a public health conversation about that. You will all know the stats around particularly physical health as well as mental health. And so I haven't forgotten that, but we're still working on kind of what the sort of 2 or 3 things that we can do across London collectively together will be. And we'll hear more about that over the next few weeks, Kevin. So there's a small number of priorities, because if you have too many, you just end up doing nothing. Our issue at the moment is catalysing them and commissioning things once. And that's what we're kind of going to get into as the ICBs kind of sort of enter their next chapter.
I think that discipline of prioritization and focus for impact is one that I think many of us working in health and care systems find difficult to do.
Yeah.
And it doesn't mean that you're going to drop everything. Necessarily, because you can't, because you're dealing with a patient with multiple conditions and so forth. But it does mean reserving your energies, time, partnerships to enhance in a few areas, to, in a sense, demonstrate that working differently with impact can generate impact, but also to test new models that can then help other areas of practice. And that's how I view the transformation projects as well. And one of the ones that will help us on the treatment to prevention shift is the work on CVD prevention that we're working on as well. And of course, Million Hearts and Minds for London.
Should we just talk about that? I know you've got other people to come in, but when I was talking about data, Million Hearts and Million Minds, of course, using some of the new techniques for sort of data mining and forward looking is so important, isn't it? So I don't know how you think about that as a public health professional, but it's quite a different like a lot of this program will be kind of traditional things that we've done to get community trust and buy-in, but some of it is kind of mind-blowingly different, isn't it?
It really is. And in an environment, Caroline, where we have digital tools and technologies where you can empower people to measure their blood pressure, measure their cholesterol, get those data into the NHS app, and to quantify and measure themselves and to be more engaged in their care is exciting. So if you can combine patient activation with better data to identify gaps, with clinical system service improvements, I think we're onto a winner. And that's why CVD prevention is such a big priority, both in a 10-year health plan, as well as in our transformation priorities for London as well. And I'm really excited about that too. Now, Caroline, I wouldn't let you go without asking you a few personal questions, or at least one in the time that we have available. And it is so challenging for all of us as leaders as we go through change, transformation, and so forth. The question I often am asked is, how do I maintain my resilience? How do I maintain my, positive outlook or pragmatic outlook? And how do I navigate these times? Any top tips you'd have for colleagues listening today in terms of how do we take care of ourselves and others during this time?
Yeah. Well, the body and the mind are linked, aren't they? So you've got to look after your physical health as well as your mental health. I practice mindfulness. I have done since I got diagnosed with MS quite a long time ago. So that's been really helpful. And then having read the newspapers on the weekend, I wish I hadn't. So I think there's something for me in this era of complexity and difficulty where we just, you have to focus on the things that only you can control. It's that thing of, and then you do start to become sort of slightly less anxious. So I think physical and mental health, both really, really important. To stop reading the newspapers. Oh, read the FT. I've just started rereading the Financial Times. Brilliant. It's really objective. I mean, some of it's a bit dull, but in terms of understanding where tech is going and where the big global interests are, it's quite important. That's better than reading any of the other broadsheets. But I mean, without wishing to be glib, I think it's you have to, having a mindfulness practice for me has probably been the biggest shift I've made in middle age to keeping a clear head.
Yeah. Thank you. It's really, really lovely to hear that. And mindfulness is also something that I practice as well. And I think the ability to learn how to, in a sense, mute the noise and to focus on what's important, and then to be conscious of your physicality, your thoughts, and so forth is so critical, I think. And you and I often talk about the struggles of going to the gym and being physically active, but when we do it, we love it, right?
So, yeah. I've started running again, Kevin. I'm back to 3.5K. I'll be back at 5 soon.
Well, colleagues, you heard it here first. Caroline, thank you so much. Really lovely to have some time to reflect with you on the transformation that we're going through now. As I said, this Public Health Forum is reflecting on leadership, because it is the challenge that we're all being called to step into and to occupy. And whether you are at the beginning of your public health career, you're a trainee, or whether you're starting out, you're a consultant, you're a director of public health, it's understanding the dynamic nature of leadership, the dynamic nature of the environments that we're working within, but also how we protect ourselves individually, but also think about the systems that we're leading to be effective. So, Caroline, I think you really helped to bring that together. So with that, Caroline, thanks. We're going to pause and we're going to invite you back in a few minutes to join the panel discussion where we'll be getting questions from the audience. But at this point, I'm going to hand over to my colleague, Vicky Hobart, who is works with the GLA and is the public health lead in the GLA and also one of my deputy directors in OHID London. So Vicky, over to you.
Thank you, Kevin, and thank you, Caroline, for the candid comments. So I have the pleasure this morning of working with some colleagues that we work carefully and closely together on a range of issues, really to take some brief reflections on leadership journeys over time and how we're applying them in the current context. So as Kevin said, I have a slightly eclectic role, slightly new role still in the London public health system. So I head up the public health unit at the GLA, and in support of Kevin, I operate as a health advisor to both the Mayor and the Greater London Authority that works in support of the Mayor's ambitions, the Assembly that have a role around scrutinising matters that the Mayor's up to, but also what matters to Londoners, as well as the GLA group. So I've had the pleasure over the past few years of working more and more closely with colleagues in transport, the Transport for London Mayor's Office Police and Crime, the Fire Commissioner, and some of the development corporations. And in broad terms, the public health elements that I'm focused on are around health and all policies. So those shaping those wider determinants of health, where the mayor's levers are, but also health resilience. So to Caroline's point around looking ahead, looking at strategic risks for the health of the population of London, me and my team are also quite focused in that space. So I was going to kick off with some introductions from colleagues. Delighted to welcome them here today. And I thought maybe we could start with a bit of a regional perspective through to local. So I'm going to ask colleagues to come in and introduce themselves and just to reflect very briefly on values that they bring to their leadership. So in public health terms, we're quite used to, and a lot of our training goes back to questions around equity and social justice. So thinking about health needs and how they're best met at a sort of population level. I'm going to bring colleagues in to introduce themselves and their roles, and just to give a quick reflection really on those values that are important to you in your own leadership. So I'm going to kick off with Will Huxter.
Thanks, Vicky, and great to be here this morning. So, yeah, I'm Will Huxter. I'm the Regional Director of Commissioning within NHS England here in London. And in relation to this session today, there's probably a couple of things to highlight. One, that as part of my remit, I cover our public health commissioning responsibilities within the region. So vaccination, screening, dental public health, what we do around health and justice as well. But also picking up on some of the themes of today, I also am one of the SROs for our work on integrated neighbourhood teams and neighbourhood health and care services for the future, which are a really important bedrock for how we look at equity, how we look at the needs of the population and focus from a London-wide framework right down to a local community-driven focus on services. Many of the values that have been talked about already by Caroline and Kevin are incredibly relevant here. For me, one of the reasons I'm passionate about working in this space is the enduring nature of the inequalities and inequities that people in London face. There are so many fantastic things in London, but not everyone gets access to them, and we need to do things differently to approach that. So I've got an enduring commitment to trying to tackle that. And the range of things that I deal with, think of that health and justice aspect of things. Visiting people receiving healthcare in prison is a salutary experience because those people are receiving services from very dedicated staff, but in environments where there are all sorts of reasons why it's really difficult to get good physical and mental health. The only thing I'd really add in terms of values for me is all of what we do is about people and how we respect people, how we treat people as individuals. I know we're going to talk quite a lot today about change, but we need to understand where people are at, listen to them, and make sure that their experience as staff, as well as in our broader communities and partners, is one where we are respectful, we listen to them, and we arrange things in a way that, and describe and explain things in a way that is truly embracing of them and the great diversity among our teams. Thank you.
Thank you, Will. Introducing now Yimi.
Good morning. Thank you, Vicky. Good morning, colleagues. I'm Dr. Yimi Chow, and I'm the Regional Deputy Director for London in UXA. And for me, the value of leadership lies really in three things. It's about talking about how, and that's in partnership, in engaging our communities or in authenticity, and this transformation and intelligence piece that I just heard. For me, it really resonated about the pace of change, the dynamic leadership that we need, and how important our partnership across the whole London is. And that is relatively solid across the London Health Leads, as well as in other engagements that we do. But it is that transition piece I worry a little bit about as we go towards where we want to get to, and just the working together, stronger partnership, coordinating, making sure we don't drop anything as we go along, as we transform. And then when we do get there, it is about working at every level, not just at regional level, but at national and UXA level, as well as all the way through to a hyper-local level. It is exciting to get into the integrated neighbourhood and ensure that some of the health protection aspects is absolutely in there, whether it's vaccination, and we talked about child health as well as preparing for any emerging infections in EPR. And of course, AMR affects hospitals, and all of those things that we've focused on before, we mustn't lose those as we move along. But we need to do it, as Kevin said, with engaging communities authentically. And that really resonated with us. We've really thought about that in UXA. We're trying to always to embed health inequalities across our strategy, but also use behavioural science in a much more intelligent way in trying to understand and try and maybe dissuade some of the misinformation out there, although that may not be the main focus. It is still, for the majority, it's increasing access, making it easier for people to get what they require. And then that last transformation intelligence piece was really interesting from Caroline. And so again, we are really thinking about where the digital assistance is, where is our front door, how do we enable consistent but actually relatively tailored advice for all aspects of health protection. And I know Susan Hopkins, as our Chief Executive, is very interested in that area too, and will be driving that along. So want to embed all of those thinking together through NHS, GLA and OHID and through our local working.
Thank you, Yumi. And Yumi, just for those that are less familiar with your role in UK Health Security Agency, do you want to just give a quick explanation of your role?
Yeah, my role is that I'm well, basically there are 9 regions in UXA, and I have the local responsibility of making sure health protection aspects are embedded in London. So UXA, we have a regions directorate, and within that we have a local leader for every single region, and I have a multidisciplinary team working all aspects of health protection, but obviously embedding very much in with the local partnership of yourself and Kevin and Caroline and others.
So that regional overview. Thank you. Thanks, Yumi. Andrew.
Thanks, Vicky. Great to be here. Andrew Bland. I'm the Chief Executive of one of the ICBs in London, South East London. I'm also, as been alluded to, I'm one of the SROs for integrated neighbourhood teams, and now sort of a neighbourhood health service being developed in the capital. So they're my sort of 2 lenses into this conversation. I also last month finished my 25th year in the health service, in which 23 of them have been working in London. So I'm kind of in love with the place a little bit as well. To the bit around, I'll just be repeating in terms of the values I'm sure people on this call share. So I was just thinking about what felt most amplified for me at the moment. At the moment, I feel really accountable for what happens to our populations. So I think there are a huge number of people that I respect and love dearly who run institutions, be they hospitals or other things, and they're relentlessly focused on excellence and experience of their patients and the care that they get. I feel very responsible for the populations of South East London, in truth, of all the people that we're planning for as commissioners. And because of that, I guess it's then given me a very clear focus on wider determinants. So in my day-to-day, clearly there's a lot of NHS-ness about it, but we're interested in housing. We've developed a health and housing coalition in South East London. We're launched our voluntary and community sector charter to make sure investment is focused there. We're very interested in people's employment. The wider determinants are really clear there. The second one that feels really amplified is just being honest. So whether we're talking about our staff or the residents in receipt of our services, these are tough times. And so I guess the thing that I'm very focused on is, am I speaking with authenticity? Am I being honest about what we're doing and the reasons we're doing things? Because they're not always sort of easy choices. Outside of that, I'm very ambitious for what we can do in the capital. I'm clear that you're only going to realise that ambition if you have an inclusive approach. And then, like you, Vicky, equity and social justice are the reasons that I'm turning up each day. That's what I want to be involved in.
Thank you, Andrew. And I'm going to bring in Will to introduce himself and give a quick reflection. Will.
Thanks, Vicky. I'm Will Maris. I'm Director of Public Health in Harrogate. I'm also co-chair of the Association of Directors of Public Health for London. So I think I'm probably giving a bit of a local authority perspective, and just wanted to big up. I can see there's 230 people on the call, so thank you all for coming on a Monday morning. A number of you will be from local authorities, so I just want to big up the local authority people. One of the things we haven't talked about is the things that we're doing already, and that is actually gives me a lot of positivity. I think someone talked about remaining positive. So Vicky, I can see you on my screen now, and then I think about the changes that we've made in improving the air quality of Londoners in the in the last few years, and the courage that has taken both from the sort of professionals behind the scenes, but also politically in sort of fighting down and things like the expanding the ULEZ. But that is going to make a real difference for our population. And then I think of the teams in local authorities doing absolutely fantastic work with their partners in ICBs and at the regional level. So the numbers of people getting treatment for drug and alcohol recovery has gone up significantly due to the investment and the work we've put into that. The work that our health visitors and our teams working with children and young people do on a daily basis, to improve school readiness and tackle some of those inequalities that we've spoken about. So positivity would be a real one for me in terms of leadership. Like, it's a Monday morning, isn't it? We've all got the weight of the world on our shoulders. We're getting into, going through the gears as we get into the day from the weekend. And how do you remain positive? But there is so much to be positive about, particularly, I think, public health, NHS in London. We are doing fantastic work in spite of the headwinds that we face. Then the other thing, people have talked about, a number of people talked about people and working with communities. And what I find, again, really enthuses me is when we kind of get out of our comfort zones, get out of the offices, and we speak to people and we speak to our communities, they want to take ownership. They want to improve their lives and solve these problems. They're not looking for us to do everything for them, to hold hands all the time. So I think that working with communities. And the other thing I would say as well, I heard Kevin Fenton, who's introduced this session, he spoke at a health equity conference that we had in my ICB in North Central London. And it was incredibly inspirational listening to Kevin, in a room face to face talking about inequalities. And I got so energized from that. But I guess we can't all be Kevin. Kevin does things his own way. And I know every person on this call can make a contribution in their own way. And Kevin sort of inspires me to think, well, how do I make my contribution in my own way? And I hope I can do that with my team. They've all got different strengths, and how can we all bring those to the efforts that we need to improve the health of Londoners? So I would encourage people to think, what is the one thing I'm going to do as a result of this call? Maybe pushes you out of your comfort zone a little bit. So the thing that I talked about earlier, I need to get out into communities more and speak to people. My comfort zone is, being in the office, being with fellow professionals. So I need to get out of that comfort zone. So what is the one thing, as well as your strengths, the one thing that you're going to build on over the next weeks and months after this call? Thanks.
Thank you, Will. And certainly that the idea that certain leadership experiences are amplified, that really resonates with me, Andrew. And your point about courageous leadership, Will, and what that brings, very important. And I think in preparing for today, I was also struck how much my mind was taking me back to big historical changes and how we've worked through in London across different sectors at different points of significant change, through what seemed at the time some very, very significant changes. The GLA is 25 years old. There's a definite retrospective point where it's looking at, well, what has strategic leadership in London achieved? And I think a number of us would recognise, with the Lansley Forms 2010, planning the transition out of primary care trusts felt fairly existential. We can also point to lots of achievements. We have 5 years of additional life expectancy in London since the point where the GLA was established. So there's a lot to draw on, both from being courageous and understanding what that means for our own practice, as well as bringing through historical practice and learning to what we're doing. So we're going to touch on reorganisation. I think if I just bring in Will and Andrew on this, so we have got reorganisation and restructuring going on. I think people on the call will be interested to see from Will and Andrew's perspective, how's that going? How are you managing uncertainty, and how are you maintaining positivity? And I think, yeah, for Will and Andrew, we'd really welcome your reflections on that. Will.
Thanks, Vicky. So, yeah, it's been mentioned quite a lot. So from an NHS England point of view, we're obviously going through the early days of really substantial reorganisation as the organisation formally folds into the Department of Health and Social Care, and we look at what the regions within that will look like and how we work with our ICB colleagues. So again, thinking about areas that I've got responsibility for, including our public health commissioning, looking at the future location of those, what is the resource attached to them. There are a lot of areas of question and doubt. And I mean, to be honest, it's difficult, and it's difficult because we operate in a space where some things are clear, some things change quite a lot. Headline pronouncements take a while to work through, and we hit some of the realities about the difficulty about how things work, and then we're engaging with lots and lots of staff, which is incredibly important. So I think what's key to me in all of this is being honest about where we are. I don't pretend to people that I know the answers about what's going to happen, or I don't. I think making time to communicate with people really, really regularly, even if it's to say there's no more news this week, but this is what I anticipate will happen next, it's important. But also trying in all of this to be really clear about what we need for London and how could that best be delivered. So there's a sort of advocacy championing role that has to be informed by the expertise of colleagues on this call and others who are saying to me, this is what's really important to us, this is how we could work together in the future. I think it's a really it can be quite sapping for people. So for me, there's a whole piece about how we encourage and support people's personal resilience. So whether that's from a general health and wellbeing point of view, whether it's about volunteering opportunities, whether it's just about talking to people about books and films and going out and having a coffee, there's a sort of human role, which I think is incredibly important in our leadership through this. And I suppose one of the things that most keeps me going is knowing the things that we do at the moment are important for the population, and we need to find the best possible way with all the constraints that there are around us about making sure those continue to be met, and some of them even being met in better ways in the future. So there's always opportunity, even amid this change. I think it's really important to keep that perspective. Thanks, Vicky.
And Will, just thinking about that in terms of the 10-year plan and opportunities that may present going forward for improvements in population health. Obviously, we're working through a big change process at the moment, but what are you starting to see as some of the key opportunities for public health coming out of the 10-year plan?
So I think there's a real opportunity for London to shape what is the London version of the 10-year. Of course, it's the national document, but we've touched already on some of the great public health work that's happening in London. So I think we've got two main opportunities. There's the how we embed it and take it forward at neighbourhood level. What is the work around prevention? What does that work interacting with individual patients and the public about their health and their care and how they can do more in the prevention space? But there's also what are the frameworks for things that we do collaboratively across London, like A Million Hearts and Minds and other areas where we can really make a difference. So I think there's every opportunity, but we have to be really clear about anchoring it in the needs of the population and where we can really collaborate to make a difference. So there's a whole partnership piece across all people working in the public health field that we need to build on.
And to Caroline Kevin's point around picking some high level priorities, that would definitely resonate for me in terms of, for example, how my team work with yours on such a range of issues, but actually what are the things that we're really, really pushing on. Andrew, from your perspective, South East London ICB, restructuring, what are you seeking to achieve? How are you staying positive?
Sure. Well, look, since the middle of March, we've absolutely been going hell for leather on a restructure of what ICBs look like. And I kind of think of it in sort of, we're trying to grow something and we're trying to protect something, and then we're doing something a little bit odd. So I think the thing we're trying to grow and establish is a strategic commissioning focus and function around populations. And obviously in our case, that's for South East London. I've come to learn that you have to be big and small simultaneously for any of these London jobs. So we've got to have a population focus at Catford, Lewisham, South East London, South London, London, you name it. And so we are doing that. And strategic commissioning, I guess, is as it sounds. To be clear, I'm pretty sure Will's done the same. I've been in a PCG, a PCT. I've been in a CCG, clustered and not, ICB, probably clustered and currently not. But they're all versions of population-focused commissioning, and we are very much back to that. I think there's good news for, I'm delighted to be on this call, good news for public health professionals. We need you more than ever. So if I look at the ICB blueprint, or the document that's describing the type of organisation that I'm being asked to sort of pull together, all over it, health economics, actuarial skills, evaluation, epidemiology, evidence, data. And I worked in a PCT. It's probably the time where I felt closest to the public health department of the places I was working in. And that is sort of, for me, the place where you really got a good insight into populations, what's important to them, very often not the health service, by the way, and then how do you plan for that? The thing that we're trying to sort of protect a bit is there's a lot of things that ICB does at the moment it's intended not to do, but we've got to get there first. So there's a number of delivery functions. I've got a lot of staff, nearly a third of my staff are currently in the business of continuing healthcare assessments and packages or giving medicines optimization advice. And in future, it's intended they won't be the roles of strategic commissioners, they'll be done elsewhere. So we're sort of transitioning. Then the odd thing we're doing is we've decided the price it should all cost before we've worked out how to do it. So I will need to spend £19 per head of population on my organisation, which is a 50% reduction on what it used to cost. But usually I work out what I'm doing before I work out what it costs. And so that feels like a bit of an odd thing to do at the moment. And so that's, I find that difficult. I've got a concern, but also it's the bit that keeps me positive. So in London particularly, I'm sure it's true of other ICBs, but in London particularly, the sort of the privilege that I get, and the bit that excites me is the convening of partners. So in South East London, we're interested in the wider determinants of health. That means local government's a massive part of what we're doing. That means our hospices are a massive part of what we're doing. That means local people are a massive part. So what I'm really important to me that through this change, we are clear that we protect that convening role and recognise the value of it. Resilience, I don't want to repeat, I do go for a run occasionally. It's my most hated activity, most rewarding when it's finished. So, but I do have a 5-year-old son who makes me answer sort of a very simple question: why did you do that each day? So then I have to explain. In case you don't have a 5-year-old son available to you, you can borrow mine at any point for babysitter or otherwise. It is quite important at some points just to sit back and say, why are you doing that? And very often the answer is because residents or patients will get a better deal in London. It's quite, I think, easy from my point of view to stay positive if that's a bit of a test you're applying each day.
Thank you, Andrew. Fantastic. So Yumi, I'm going to bring you in now just to give us just a flavour of how the changes are impacting on your function at UK Health Security Agency. Maybe slightly less of the structural change, but you've obviously been through quite a bit of change, a relatively new agency. So just a few words on where you're at as the health protection function for London, and then what do you see as the key opportunities coming out of the 10-year plan?
Thanks, Vicky. As you say, we've not been without change in our career of sort of 25 years. I've definitely seen a lot of change, and in the health protection space, we definitely have seen a lot of change as well, as whether it's through PHL to HPA to PHE and now in UXA. But I suppose all of that is that we're all moving towards similar things, and throughout this change, all of it is about focusing more on our preparedness and biosecurity, focusing on whether we need to amend our statutory powers, and even more so towards health prevention and tackling health inequalities. So absolutely, we're there to help to decentralise and be hyper-local as well. So Vicky, you were just asking about what we're seeing as changes.
So what do you see as the key opportunity, some of the key opportunities coming out of the 10-year plan?
Yeah, so I think some of the key opportunities are improving on what we've already done. As Andrew said, there's a lot that we've already done, whether it's things like the future health protection co-design group that has come together in 2022 as a result of COVID. So making sure we learn from previous mistakes and previous incidents and understand the opportunities and build that in. I can hear the things that we have done in that include sort of health protection assurance frameworks, include a memorandum understanding, and some of that will act as guardrails of when we go along and improve our change. Some of the bigger opportunities, like you say, is about thinking how public health and health protection in particular is also embedded in the commissioning agenda of the ICBs. And so that will be really exciting to be able to help and shape that for health protection. And the last thing, I suppose, is that thing that you just said, Andrew, why are we doing what we're doing? But what's important is also knowing why we're not doing what we're not doing. I think is the other side of the coin. So when we are thinking through commissioning for, and in particular health protection aspects, whether it's vaccination, which is one of the big things that we really do need to get on top of in London, it's still, well, why won't we do something else? Something has to give. So if we're doing something, why do we want to focus on that? Why would we prioritize that? And if we're not doing something else, be transparent about it and know when we will pick it up and understand when we'll pick that up. Lastly, I think workforce, I'd be really anxious about keeping and containing our public health and health protection capacity and workforce as we move along through the transition. So any way we can help professional colleagues ensure that we keep our capacity, keep our momentum, and keep public health, which is core to a lot of transformation. Happy to help.
Thank you, Yumi. So I'm keen that we have some time for Q&A. I'm going to bring colleagues in a minute just to give a reflection, one reflection on what would you like to see in a year's time in the public health system in London? What would your key thing that you'd like to be seeing in a year's time? I think from my perspective, and Will, I don't know if you want to add to this, wider change happening. We also have the English devolution bill, which is looking a lot at the kind of political arrangements, governance, oversight across the country. Quite a lot of change there. There's also an agenda around public service reform, particularly across a range of public service organisations, as I say, fire brigade, work with the police, etc., which throw up a whole set of new opportunities. I think good news is that the current mayor has a health inequality strategy, and he's very interested in how we drive collectively and through collaboration improvements in health improvement and health equity for the city. And the English devolution conversations do throw up new opportunities around that. Will, a couple of words from local government. How's it feeling in local government at the moment?
Yeah, I'll just be brief. So individual boroughs are all different, and we're not, I already feel, and sending solidarity to those other organisations on the call have to go through significant and often disruptive sort of organisational restructures. That's not the case in most local authorities. But what is the case in most local authorities is extreme financial pressure due to the burdens, particularly around homelessness and temporary accommodation and children's and adult social care. And it doesn't seem like we've got a solution to those problems. So it is tough in local authority, but I think we're delivering really good quality work across local authorities and with our partners on the call, as I said, particularly on the sort of public health front. Thanks.
Thank you, Will. So reflecting on what the public health system might be like in a year's time and what we'd like to see, my own reflection would be back to the point around a small set of collaborative priorities where we're pulling together to try and, well tested, but to make a real difference for the health of the population. But seeing that supporting our political leadership. So that is the mayor and the assembly, but it's also our local councillors and leaders or mayors of local authorities, but with MPs. So I think that explicit, they need support, they need to understand. And the more that the public health system, I think, can be supporting them with evidence and a sense of priority and an understanding of how they can provide political leadership for what we're trying to achieve would be a great thing. So I'm going to bring in colleagues now. 1 year's time, Will, what would you like to see?
I think what's really important in 1 year, so we've talked about a load of change. So there's So absolute priority for me that there's resilience, visibility, impact of the public health functions that we've been talking about in this call, and that is able to be used to drive commissioning and delivery decisions at all levels of health and care. So that's incredibly important. Without that, we're really going to be stymied. I also would like to see progress on some of the key areas that we talked about, whether it's the Million Hearts and Minds, whether it's Yemi was highlighting where we are on immunisation rates. There's a range of really tangible things within that. But I think it's most important to me is that amid all this change, we don't dilute, dissipate, as the most extreme word, destroy that brilliant community of expertise that we rely on so much for what happens now. And as Andrew was describing, in terms of what's required for the future, really, really key skills to enable us to do what's required. Thank you.
Thank you, Will. Andrew.
Well, I think the very simple answer is I want you to either come and work for me or with me as an ICB in greater number. I mean, in a year's time, if we see public health input everywhere, it's certainly going to help us with that strategic commissioning piece. I think more directly, please don't underestimate the opportunity for us to do a great thing and look outwards as the NHS and as an ICB, but also times are tough, and I think Kevin made the point, perhaps Caroline as well, to look inwards. So I think that sort of challenge to keep a broader perspective beyond the health service for some of these solutions, and in particular, and my experience is that public health colleagues have been a fantastic bridge between health service professionals, NHS decision makers and local government. And I think at the moment, really, really important that the colleagues on the call, if you're in a position that allows you to do that, you really see that as an important part of your working week, please.
I'm hearing a strong plea there from the NHS for colleagues, public health colleagues, time to roll up our sleeves, get stuck in. Yumi, one thing very quickly, and then we'll back to Kevin.
Yeah. So I suppose one thing that I'll probably want to see from AXA and to improve all the system is really future-looking multi-source intelligence to help us shape the wider. We're very good at trends, we're very good at surveillance, we're fairly good at the traditional, but I think to help this whole of the local system move towards all our goals, it would be much more tailored intelligence that will be able to help us commission the right commission and then get the outcome what we wanted, which includes, of course, increasing our vaccination rate in London.
Thank you, Yumi. Thank you. And Will?
Just very quickly, and one thing we haven't talked about a lot is not necessarily going to take a year, but being on that journey to have, this is about leadership. So diverse leadership, building that capacity, building our workforce, allowing those pathways for people who really represent London communities to be in those sort of leadership positions in public health. Thanks. Thank you, Will. Kevin, back to you.
Wonderful. Thank you, Vicky. And thanks to the panel for a great discussion. We've had quite a number of questions coming in from the chat. I'm not sure if Caroline is still on the line. I know she was having some technical issues. But while we wait for her to rejoin us, there are going to be 5 questions that we'll have to tackle in 5 minutes. Rather than having a panel discussion, I'm going to direct a question to each panel member based on something you've said or an area which I think would be really interesting for you to reflect on. So I've dropped the 5 areas in the chat. So we'll start with AI and public health. And Yemi, I wondered if you wanted to reflect a little bit. I think you were just reflecting on the promise of AI in the chat. I think colleagues have been reflecting on, some of the risks that we have, and at the pace of development of artificial intelligence, are we in danger of falling behind, and how do we mitigate that? I wondered if yourself or if UKHSA have been in that space and thinking about how we leverage the technology but put safeguards in. And then Caroline, I'm going to come to you to reflect on how do we measure success in ways that are much more holistic and comprehensive rather than focused on activity. So Yemi, we'll start with you. Any reflections on AI?
Yeah, so Kevin, like you say, this is a space that we have been looking at in UKHSA. It is what should it I suppose because we deal a lot with not only big data, but we also deal with lots of individualized data, that's where it gets challenging. And that's where the governance, and as well as the NHS, the governance of that is really fundamentally important to us. However, there are lots of sort of ways of trying to use and the data that we get in a more intelligent way. So we're expanding on sort of more predictive elements, like you say, wastewater surveillance, water surveillance, things that will give us a sort of a bigger picture, and then some computer generations and assessments. And as you know, we all in public health are part of risk assessment. That's what we do every single day. And I suppose part of that in AI is incorporating that into our risk assessment. Of course, it's not without its risk, and we do need to make sure we have good guardrails in to ensure it's safe.
That's right. It's the guardrails that we need to have in place. And that might include regulation of the companies, regulation of the AI models, and understanding what's the content, the inputs which inform the outputs. But I think we need to have a much more strategic approach to how we apply AI in public health practice. And as you say, from diagnostic technologies to how we use big data to understanding communities and how we engage people in terms of engaging in their health as well. So I think this is an area which would be really good to come back in the forum to focus on in the future as well. Caroline, there's a challenge that we have in a complex dynamic system that we focus on the wrong metrics. How do we change that? And then Andrew, I'm going to come to you about strategic commissioning. If we are going to change the way commissioning is being done in ICBs, how do we really take full advantage of what's coming up next to shift the way we've done commissioning for better population health outcomes? And then I'll come to Will for the next question. So Caroline, over to you.
Great. Okay. Well, so you and I both know that most of the really important things are longer term in nature. So morbidity and mortality are things that cover longer than a kind of quarterly or annual league table, which is kind of what we're looking at the moment. So, but you can't ignore the fact that politics is the NHS and health is a very political issue, and it does get quite short term. I was thinking about some of the things that. So those of you that are in North East London will know that we've got a coaching project going on at the moment where we are trying to engage patients who are at most risk of needing kind of hospital appointment or pitching up at A&E and then coaching them. And actually, there is a bit of a correlation between hospital usage and kind of overall health and morbidity. So, and that project in North East London is having some good short-term results in terms of kind of just reduced unexpected admissions for the coached population. So big tick. So that was one thought, that some of these short-term indicators can be useful to us in the longer term. But then I was also thinking, I began my career in the 90s and we had things called health action zones, which of course transcended political cycles and allowed us to really judge ourselves. So I think I'm going to give you a fudgy diplomatic answer, which is it's both and. We need to do the longer term stuff, which no doubt we will do with Million Hearts, Million Minds, as well as then the short term. Okay, do these interventions really make a difference on my usage of the health system in the short term? A final thing, Kevin, I think is we need to put ourselves in the place of the patient or the consumer of health services and judge what matters to our population, and that's the stuff will then drive behavioural change. And we don't do that very much. The league tables that we've just come out are really not about me as a person. They are about us as a political system. So we need to get that balance right.
Yeah, you're absolutely right, Caroline. I mean, how things could look different if some of our metrics were on the quality of the partnerships and collaborative activities that we do. If some of our measures were about the relative allocative efficiency of our investments, are we investing the monies in the right place, and are we shifting in the right place to have the population health impact? There are many other measures, success measures that we can look like, and I think as leaders, part of the challenge is continuing to advocate for getting beyond activity metrics into the metrics that really matter and that can help to drive system change. So with that, Andrew, speaking of system change, strategic commissioning, it's the big buzzword for the new ICBs. What must be different for it to have the sort of radical shift that the government is looking for in a 10-year plan? What are some of the prerequisites for success?
So, well, just to the previous point, just very quickly, be careful what I wish for, because Caroline's also my boss, but I've been escalated for not doing the money very well or for A&E performance of primary care good at some point to be escalated. The quality of our collaboration was not good enough, and I think that would be a really helpful for across the piece. Look, I am concerned slightly that at the moment, if we were going to train the workforce for strategic commissioning, we would need time and money, and I don't think we have either. So essentially, communities of practice or ways in which to get transferable skills from colleagues on these calls into the types of teams that we'll be working on, really important. But I just wanted to stress two things I felt, just in terms of the real world implications that you talked about, Kevin, and what we're spending money on and the reasons we're spending money for it. I think there's got to be a real sense that strategic commissioning is driving understands a return on investment. So I'm with you in terms of some things we might do with a NHS buck, and so the Barnet pound or the London pound, that might then mean that people are back in employment quicker, or we'll see something happen with the welfare bill, for example. We really need assistance with strategic commissioning of a different kind that understands the totality of that public sector spend and where do the benefits fall and how can we connect one to another. Secondly, I don't moan and make the point, it might come across moaning about our annualised budgeting. And so, but I think if we were able to make a return investment case, as you often have, Kevin, I'm sure colleagues on the call here, to say money here will result in a change there with definition, then I think strategic commissioning flies. So I think I'm supposed to say that we'll perfect actuarial skills, our commissioning cycle will be perfect. I think there's a few things here. One is, are we calling out collaboration as important? Secondly, can we have a rigor around return on investments? We confidently ask for multi-year budgeting, and can we have at least for London or perhaps South East London in my case, an understanding of where the benefit, financial or otherwise, is coming from, where a pound's spent. If it's not the same budget line, can we make that still possible? And I haven't achieved that yet. That's my hope for strategic commissioning going forward.
Okay. All right. Thank you, Andrew. Really important points there. And throughout your entire answer, you can see the importance of public health practitioners informing almost every phase of what you just discussed. And I think the challenge for us in the public health community is ensuring that we are both training current and future generations of public health trainees to be able to do and understand their NHS-facing public health work, but also ensure that we're well placed wherever we are in the system to continue to support that journey that you've mentioned, Andrew. Now, Will, I'm afraid we only have a couple of minutes left, but I've saved the best question for last, and that's a question coming in from Nicola Ensor in the chat. And she's asking, when are we going to see public health, population health management, genomics, mental health working together to really look at how people can make the best use of their resources and their lifestyle, and a much more holistic approach to prevention and thinking about population health outcomes? Maybe a very polemic question to end on, but I wondered if Will Maris, I'll start with you, and then Will Huxtell. Can we move towards this more holistic, this more integrative way in thinking about prevention and the role of the NHS?
Yeah, I was hoping he'd say Will Huxtell first, because it's such a intransigent question. My wife actually she's a doctor and she does immunology, but she's also done a master's in genetics, and she was involved in something called the Topol Review, which is I think 2019, and which looked at things around kind of genetic capacity, how we use genomics in combination with epidemiology to get a more personalized service. I don't think we're there yet, and I think actually with genomics, it's quite challenging to do that. Like, you can do genomic analysis at population level, but it's not as sophisticated as maybe we think it is. So I don't think the answers are quite there yet, even from the sort of technologies that we have around genomics. We talked about a million hearts and minds potentially, and at the moment we are looking at those kind of the traditional way of looking at public health, aggregated data sets. Which populations do we think we're getting a signal for? So I don't know the answer, but I would like us to work towards that, so kind of true population health management. And I think that's something that we can, particularly as we're developing the neighbourhoods model, we should be thinking about. There is also work, as I understand it, around the genetic medicine service, which is probably beyond the context of this conversation. But I think, Kevin, you and I have had conversations with someone who's leading that at London level, and there is proposals to do a lot more of that sort of population level genomics. So it might be something we can bring back to this forum as well, or other forums to talk about. But yeah, I'm not the expert and I don't have the answers.
Good. All right. Thanks, Will. And Will Huxtell, final word. Any reflections on the
I
direction.
agree that it's complicated, but I also think that it's looking at population need at a very local level that is going to address it. And Caroline and I were both at the London Mental Health Board a couple of weeks ago, where we talked about multimorbidity in people with severe and enduring mental illness and how that is addressed. And unless we look at all of these things together, we're never going to target not just resource, but also support individuals to take more control of their lives into the future. So I think definitely the answer is at the most local level, but it's also championing that sort of holistic, joined up approach as what we want to be consistently applied across London.
That's absolutely right. And don't underestimate where we have those glimmers, right? Where those emerging shoots where this sort of integrative approach is already beginning to happen. So whether it is in dealing with blood disorders, the thalassemias, sickle cell, whether it's thinking about how we integrate genomics with chronic disease prevention to have precision prevention and personalized prevention interventions. So we are seeing elements of this appearing. I think the challenge for us is to learn as we're doing, share best and promising practice, but keep our eye on the prize that actually there's a whole world of enhancing prevention that we can move into when we begin to integrate what we know about communities and people, what we know about technology and how we use it, how we use data better and more effectively, and then how we develop our interventions. So, colleagues, we've come to the end of our time this morning. This is a different public health forum today because it's focused on leadership. And rather than having a series of lectures talking about leadership theory, we thought it would be really important to hear from our leaders here in London. And for those of you who've joined us from other regions, I hope you've enjoyed the reflections from the city. Clearly, none of us have an answer or the answer because an answer doesn't exist. But what we do have are the hearts, the minds, the commitment, the passion, the technology, and the tools that can help us to begin to do things differently and to expect different outcomes. So I'm hoping that as we've gone through the conversation today, you've picked up different elements of leadership behaviors, leadership opportunities, leadership challenges, and leadership hopes that can help you to think about your work in public health and how you can make a difference. So just before we close, just for me to say thanks to a lot of colleagues today who've helped to make this happen. First of all, to Dame Caroline for your incredible leadership in NHS London and being a great boss and colleague. But thank you for being here because you've been a champion for public health and you continue to be a champion for public health in the city. To Vicky, who chaired the amazing panel so effectively today, to Will, Yimi, and Andrew for the stimulating discussion and being honest and authentic about the challenges and the opportunities as well. And then behind the scenes, there's so many colleagues who worked really hard to get this session off today. Huge thanks to the organising team, both in OHID London, UXA, the GLA, as well as the NHS, who worked together to make this happen. And then finally, I'd like to thank Charlotte Class. Charlotte, many of you know, had been in NHS in London, and she's been a real part of the force in developing the Public Health Forum over the past couple of years. She's now in the east of England as the Deputy Director for Healthcare Public Health. And we wish Charlotte all the very best as she continues to work and lead in public health. So, colleagues, with that, we've come to the end of our time together. The next Public Health Forum will focus on babies, children, and young people, which, as you know, is a major priority for government and a huge opportunity for us to improve health and to have that multi-generational impact on our populations. I'm excited to see what that panel will look like, but there's lots happening in this space and we're keen to share those developments with you. So thanks for being here and have a great rest of the week. Bye-bye.
Thank you.